Thank you very much, and good morning, everybody. I'd like to thank the organisers of the conference for inviting me here. I was very attracted when I saw David Jung's invitation with two key words, interdisciplinarity and a phrase, evidence-based practice, because these are two areas that have been of major concern to me for the last, 30 more years indeed. So it was a great honour to be invited, and it's always a pleasure, of course, to come to Hong Kong. Well, I'm going to try to cover quite a large area. I understand that it won't be necessary for you to take notes because a copy of the presentation will be available afterwards. And I will, without further delay, get on with this when I can check which is the best one to use to move the slides forward. Oh, that one. Okay, thank you. It was upside down, so I didn't see it. Right, thank you. Okay. Right. Well, it's always useful when you're addressing an audience to know who the people are that you're talking to, particularly in an interdisciplinary and perhaps interprofessional context, right? So I thought that we would begin with a little exercise where I invite your participation. So I'm going to show you a number of pictures, and I want you to identify which professions or disciplines these people represent, okay? And then I'll ask who's here today, right? So we'll take these pictures in turn. So here is the first one. What profession do you think this person represents? Can you shout out if you have some ideas? Counselling, yes, yes. Social work could be, yes. Psychologist, right? Okay. So a few of these possibilities here. And this next one. Social work, yes. Now, it's actually very interesting because I chose this one to kind of illustrates that there may be differences in perceptions between different countries. So this is actually a very famous fictional social worker in England. And it's a long-running radio series about somebody working as a social worker. And you notice that she's not dressed in a business suit or something similar, okay? So, what about this next one? Psychologist, right, okay, yes. Any other offers? Academic, could be, yeah, yeah. Well, let me tell you, the process that I went through to select these photos was to put into Google Images the names of different disciplines. And this is what came up when I put in sociologist. Right, okay. The others that came up were actually pictures of Emil Durkheim, for those of you who are sociologists, I'm sure will appreciate that, right? And then finally, how about this one? Secretary, right, administrator. Any other offers? CEO, okay, very good. Because actually what I put in was female manager, right? And it just actually goes to show that when we look at these kinds of representations, one of the things that is important is the gender of the person who is there. We make certain kinds of assumptions, right? Oh, and one more. What about this person? Lab technician, right. Anybody else? Well, this may surprise you. Oh, sorry, do we have an offer here? A real doctor, right, okay. Yes, yes, yes. Actually, this was what happened when I put in researcher, right, okay. So, I'll now, if you've not met this gentleman before, Rabbie Burns is the leading poet from Scotland, right? And if you can read that in a Scottish accent, I would be delighted and very impressed. So I'll attempt to translate it. Oh, would some power the gift give us, the key bit, to see ourselves as others see us, right? To see ourselves as others see us, right? And the reason why I introduced this talk with some presentations of how people see other disciplines, right? In this case, people in Google, but actually you here too, right? How other people see us. Because if we're going to talk about how professionals and disciplines work together, one of the key elements at an interpersonal level is actually to do with how these other people see us, right? And these, for those of you who are psychologists in particular, would recognize in relation to the concept of stereotypes. And there are three kinds of stereotypes that I think are pertinent. Firstly, the stereotypes held by one profession or another, about another. But secondly, also that we have our own stereotypes about our own profession, right? And then the bit that I've highlighted so far is perceived heterostereotypes. What you believe another profession thinks about your profession, okay? Now, I got into the interprofessional education at the University of Bristol. Actually, it was in about 1983. Some of you may not have been born then. But at that point, I had, perhaps rather foolishly, applied for a job which had the task of shared learning between medical students and social work students at the university. This was an inspiration of the then professor of social work, who I was honoured to succeed some 25 years later, I guess. Anyway, what she said was, well, we've got this new task, and, would you like to apply for this job? I applied for the job and I got it. I can't quite remember how. And then I said to her, well, how am I supposed to do this job? And she said, well, you're a psychologist, aren't you? Surely you know something about intergroup behaviour, which of course I did, because the University of Bristol at that time was actually probably the primary centre in European social psychology. And so the notions of understanding stereotypes and how stereotypes could be changed, how groups related to one another, was indeed fundamental to what I'd been learning about. So basically what I tried to do was to apply this knowledge to the bringing together of different groups of people. And I've continued to think that these ideas are very useful in understanding interprofessional, intergroup relations at a personal level. So what I'm going to do in this session, I've already started by talking about interprofessional perceptions, but I'm going to move on to look at the way in which policy has developed in the United Kingdom, or England in particular, and I'm going to suggest that a lot of it is actually to do with things that have gone wrong in interprofessional or interagency working. And there are two areas that I'm going to focus on, which have already been mentioned in the introduction. The first is child protection, and the second is mental illness. And then I'm going to consider how interprofessional education might make a contribution to trying to sort out some of these difficulties. And the evidence that I'm going to draw on is evidence from evaluations that I and my colleagues have undertaken over a number of years. So, in the very first program of interprofessional education that I did, we invited students to say what they considered to be the attributes of different professions. And this was a program that was designed for medical students and nursing students at the university. And they were asked about what they thought were the attributes of doctors and of nurses. And the doctors, as you can see, were thought that they were perceived by other professions as being detached, uncaring, dedicated, that's good, poor communicators, that's not good, confident, but arrogant, right? That's how they saw themselves. And actually, this work has been repeated by researchers all over the world since then, and actually they come up with something very similar. Doctors seem not to have changed in their understanding of the the stereotypes that they believe other people have about them. Okay? Now, one of the things that is important in understanding stereotypes is that you actually want other people to think about you and your profession in a particular way, like the good things about you. So that nurses, for example, are very happy to be thought about as being caring, as being dedicated, as being good communicators. But they're not happy to be thought of as being do-gooders, right? Which would construe in England at least as being people who kind of meddle and try to make things better, but without really being very professional about it all, right? So when you bring two groups of professions or indeed disciplines together, the kind of outcome that people often want is that there's been a change in perceptions towards your discipline from the other disciplines that are involved. I'm going to say more about that in a moment. Right, I suggested that policy in the UK was often led by scandal and the particular role that the press, newspapers in this case, have in alerting the general population to particular issues and then they're making a big fuss about it. And one of the repeated occurrences in the UK is of scandals to do with the protection of children, or to put it the other way around, more accurately, about the death of children. And this little boy, baby Peter, was killed by his family. And this news item from 2010 talks about the shaming of the bunglers who they construed, the newspaper said, were responsible for the death of baby Peter as much as the people who'd actually murdered him. That was the line that they were taking. So who were these bunglers? They were social workers, of course. Right? They were pediatricians. They were the police. They were the health visitors, community nurses. They were the managers of the hospital. And they were the managers within the local authority. These were all identified as being the bunglers, as it was, the expression was used by the paper, in analysing, reporting the investigation that had been carried out into the death of baby Peter. Baby Peter died in Haringey, which is in North London, and actually 10 years previously, almost 10 years previously, another child had died. And there was a previous inquiry into her death. And the man who led the inquiry, Herbert Laming, said, and this is, I think, the key quote, that the suffering and death of Victoria Climbié was a gross failure of the system and was inexcusable. Right? And I want to emphasize that. It was a failure, he said, of the system. Not just a failure of interprofessional relationships, right, but a failure of the child protection system. Okay? He said, I remain amazed that nobody in any of the key agencies had the presence of mind to follow what are relatively straightforward procedures on how to respond to a child about whom there is concern of deliberate harm. Right? The professionals went following procedures that had been laid down. Why on earth would that happen? Well, he said that the principal failure to protect the child was the result of widespread organizational malaise. It was a failure of management. It was sloppy and unprofessional performance. And the kinds of things that were happening was a failure to communicate between agencies across agency boundaries. And when things did go wrong, nobody wanted to accept responsibility for it. Okay. In relation to management, he said, management has to change. The future lies with managers who can demonstrate the capacity to work across organizational boundaries, because such boundaries will always exist. Right? He said that the safeguarding of children, the protection of children, must not be placed in jeopardy by individual preferences as to what people are going to work on. and he recommended the joint training of staff and the sharing of budgets as being likely to ensure an equality of desire and effort to make these interorganizational relationships work effectively. So we're already talking at two levels. We've been talking about interprofessional relationships as personal relationships. We're now talking also about interagency relationships. So he elaborated his ideas on multi-agency training, which I would think of in terms of interprofessional education, as helping professionals to understand the respective roles and responsibilities of the other professions and the procedures in each agency involved in child protection, in developing a joint understanding of assessment and decision-making practices, and in learning from reviews that have taken place following serious incidents and deaths. Okay. Now, the UK government, I always remember a Dutchman academic saying this. He said, I said, where do you get your policies from? He says, oh, well, we just see what has been done in the United Kingdom, and we see if they make any sense to us or not, and we adopt those. We certainly don't start from scratch, because you guys spend your life making policies. Whether you put them into practice or not, I don't know. And I said, well, sometimes we do and sometimes we don't, right? So the government, cross-government, departments of health and education, okay, in particular, promote interagency, interprofessional collaboration in relation to the safeguarding of children. And they produce a new volume of instructions, on average about every 5 or 6 years, okay? And it's a guide to interagency working, they call it, right? And the key message that they always give out is that safeguarding children is everyone's business, not just social workers and pediatricians and so on, but it's also the responsibility of librarians and firefighters and anybody else who might come in contact with children. So, if we're going to bring people together, to agencies to work together, the contention is that interprofessional education or multidisciplinary training has a role to play in that. So what do I mean by interprofessional education? Occasions when 2 or more professionals learn with, from, and about each other to improve collaboration and the quality of care. So the basic idea is that you need to bring people together to talk together about what their roles are and how their roles interlock, right? It is not interprofessional education because for the purpose of economy, what you do is simply to stick people together in the same lecture theatre because that doesn't create any change in ideas or attitudes and they don't learn about each other, right? And the 2 examples that I'm going to give are about, the 2 areas where interprofessional education in the United Kingdom and elsewhere has been developed are as part of qualifying professional programs. So you bring together people before they have become qualified professionals, and that's where I started. And then the second area is that of continuing professional development for people who've already been qualified. Okay. So the 2 examples, short courses on safeguarding children, and I'm going to talk about the evidence for the effectiveness of such training on professionals, and then longer programs on community mental health, where the evidence that I'm going to focus on is of their impact on service users or clients. Okay? So the first thing to say is that in that document, Working Together, the government stipulated that interagency training was something which was compulsory. Okay? They put it in law, in other words, right? And they created funding for it, and different agencies, social services, health, police, and so on, operated through something called local safeguarding boards. They're just being changed to something else at the moment, but I'll leave that by and by. The aims to produce a shared understanding of roles and responsibilities, improved communication, more effective case and team working, and, as I've said already, for all people working with children. Now, the procedures that are developed, and this is a classic example of British bureaucracy, can be illustrated by that. Okay? You're supposed to chuckle a little bit, but you can see that this is a complicated map, and I don't expect you to read it at all, just to get an impression, right? Now, I was commissioned by the English government to carry out a study of the way in which this interprofessional education was working, and we focused on 8 areas in the country. And we looked at these questions: how the training was organised, what kind of training, does it work, and is it value for money? So a key element of this, and we were actually rather impressed by it, was the way in which the different agencies had come together through the board in order to work in partnership and to develop a joint goal. So that kind of mirrors what the professionals themselves were supposed to be doing. And this model is actually taken from Michael West and one of his colleagues. Michael West is a professor of organisational psychology in England. And the notion that effective partnership working requires a whole range of things, starting with a shared commitment to the goals and values of what you're trying to achieve. So what kind of partnership did we see in relation to the organisation of multidisciplinary training? Well, firstly, that it was mandated, that government required it to happen. There'd often been a previous history of people working together, but we were very impressed by the shared commitment of this relatively small groups of people who took on the task of organising this training. How do we know this? Well, we sat in on meetings and saw what they were doing and looked at what they were producing. Second area is that their responsibilities were delineated. This is what you have to do. The third was that they were clear objectives. Well, the clear objectives were expressed in terms of outputs, the organisation and running of good courses, actually rather than outcomes, which I would define as being whether they learned anything from the courses. Right? And finally, they were accountable. They were accountable to the overall interagency body. So the kinds of courses we're talking about here are short courses, 1 or sometimes 2 days, usually 15 to 25 people, that they include presentations on research, legislation, local policy and procedures. But key to this process is that they're highly interactive. They're based on small groups, small mixed groups, they're case-based, they focus on roles and responsibilities, and they include lots of communication exercises between the participants. But from the feedback from the participants, one of the things that was most important to them was the informal contacts and the networking that they experienced when they were attending those courses. It was the discussion with the paediatrician over a cup of coffee, or the discussion with the police officer that began, among other things, to challenge some of the stereotypes that they had about doctors, police officers, and so on. So does it work? Well, this is the kind of research methods bit for those of you who are into that. We employed a time series design to look at people's self-report of outcomes, of measures of knowledge, self-efficacy, confidence in doing things, and their attitudes. My original aspiration was wildly over the top. I thought we might be able to randomize people to take part in training and other people to go on a waiting list for training, but that was quickly shot down by the people who were organizing it and saying, no, you can't conceivably do that. We just don't have the organizational capacity to do it. So the time series design involved people completing questionnaire measures at registration for the course, which might happen a few weeks earlier than before, at the start of the course, at the end of the course, and then a follow-up 3 months later. So here's one which is talking about how professionals might work together to safeguard children, and it provides, it's a continuation course. Right? And what we saw by the end of the program was people endorsing such statements as, I have a good understanding of the roles of different professionals who engage in work to safeguard children. Statistically large and statistically significant increase in that kind of statement from the beginning. A decrease in a statement, I lack confidence when I work with people from other professionals. Increase in, I'm comfortable working with people from other professions. And very importantly, I feel that I'm respected by people from other professions. And that's important, particularly because sociologists among you will recognize immediately that different professions have different status. Okay? And that's an important part of the interaction that takes place. So the people who are most likely to endorse this statement in England were the social workers, because they felt that they weren't respected. Right? Okay. They were also here you are, where they're recognizing that there is indeed a status hierarchy in safeguarding work that affects relationships. And that didn't change. That's not surprising, because actually the course, the programs, emphasized that actually status and a hierarchy was really important in actually what determined outcomes. So in order to test knowledge, we looked at the particular areas that courses were focusing on. And here, just as an example, is of work done on understanding disabled children. Okay? And it covers statements to do with attitudes, confidence, knowledge, and knowledge about procedures. And here is a summary chart which compares the mean total scores. And what you'll see is that between time 0, the time of registration, and time 1, the start of the course, there, in general, hasn't been much change at all in their attitudes, their knowledge. Between time 1 and time 2 is the time that they're on the course, and between time 2 and time 3 is the follow-up after the course. So what that is telling us is that looked at across a whole number of different sites, B to G, that you have a consistent pattern whereby at the end of the course things have changed quite significantly with a very large effect size. But what's also encouraging is that when followed up later, that has continued to increase because they've been able to put things into practice. So the headlines from this study would be that interagency training is liked, that it's effective in the short term, incidentally that it is good value for money, we tested that out, but can this make a difference to the lives of clients or service users? And at this point I pause to have some water. Okay, so what I'm going to talk about here is interprofessional education for community mental health. Now, actually, the same kinds of problems that I've talked about in relation to child protection have also been evident in community mental health services. And that's been particularly the case because it also involves death, right? So what you'll see is that there have been a whole range of scandals involving the murders of people by people with mental illness, serious mental illness, right? And the question has always been, well, why is this happening? Why are these people out of hospital? They should be locked up so that they can't kill people. Actually, this inconveniently ignores the fact that you're much more likely to be killed if you're somebody with severe mental illness than actually to kill somebody else, right? And that actually, as far as I know, applies just about anywhere in the world, okay? What we're looking at here is a 2-year part-time master's level program at the University of Birmingham, which was since replicated at another university a few years later. And we were very fortunate to get funding for 5 years to evaluate this program so that we could look at a number of different cohorts of the students taking part. So here is the curriculum of this course, which was basically a 2-day-a-week course that ran over the entire academic year for 2 years. And what you'll see there is that there's a beginning emphasis on the principles and values of practice, and in particular that those values should be user-centered, right? Because ultimately the argument is that these services are set up to help service users, people with mental health problems. That they learn about assessment and care planning, and they learn about that as a multidisciplinary exercise, because each profession can bring together some knowledge and understanding of why the person is in that particular situation. Okay? Whether it's the psychiatrist who is diagnosing a particular form of mental illness, psychologist who is referring to different aspects of cognitive functioning in the service user, or wanting to assess them for the appropriateness of psychological interventions. Law, of course, is important in understanding how law and policy relate together. And this program had specialist modules in cognitive behavior therapy and family intervention, and the expectation was that all of the participants in the course would learn those interventions to a sort of introductory level at least. Okay? And then number 6 there, the key focus on interagency and team working, because most of the professionals in the UK, and I believe it's also the case in mental health services in Hong Kong, are actually working in community mental health teams. Right? And the final contribution is actually about research methods, because they're doing a master's dissertation itself. So this is the framework that we used to structure the evaluation, and this comes from a well-known framework in education developed by Kirkpatrick and elaborated for interprofessional learning by a man called Hugh Barr. And he talks about evaluation at a number of different levels, from the basic learner's reactions. Okay? Now, a learner's reaction is like the feedback form that you were given as you came in. What did you think about it, the learning experience? And you'll probably be asked, I haven't looked at it, but you'll probably be asked questions about what did you think of the venue, were the speakers any good, did they keep you awake, those sorts of things. So in case you're not keeping awake, I will just wake you up to encourage you to give a good rating for me on keeping you awake, if that's the criteria. Okay? Did it modify people's attitudes and perceptions? Did they actually learn anything in relation to knowledge and skills? Subsequently, did their behavior change? Did organizational practice change, because these were professionals going back to their teams? And were there any benefits for service users? Now, the different kinds of outcome that you're looking at, I would argue, and we put into practice in this particular evaluation, require different methods. Okay? So if you want to learn about change in organizational practice, your best bet is to actually go and talk to the managers of the team that the participants have come from, to ask, what do you notice about what's happened since they've been on this course, etc. Okay? Others, you can, number 4B there, benefits to service users. Does it make any difference to their health and well-being? Well, we used established psychometric scales that are common in mental health services. Right, so did they learn something? Well, one of the things you can do is to actually ask them whether what you're teaching them is important to them. Are you familiar with these box plot charts? Okay, in case you're not, right, this is just showing the distribution of ratings. So if you look at the middle one, T1, what you see there is a red box. 50% of these students are giving a rating within that band, and the black line in the middle is the median rating. So 50% are above, and 50% are below that line. Okay, and this is a 0 to 10 scale, and you'll see, if you look at the rating of importance, that the median rating as to how important it was to learn about multidisciplinary working was 10. Okay? They all thought that this was absolutely essential. Not all, at least half of them thought that this was absolutely essentially important, and another 25% gave it a score of rating of 9. And those little bubbles that are floating around at the bottom are statistical outliers of people whose scores were actually quite different to everybody else's. So what this chart is telling us is that they thought that learning about multidisciplinary team working was important. I should say this is a total of a number of different statements that they're using. and that at time 1, the median score is around about 6, and it's gone up to nearly 8 at time 3. So we're seeing a significant improvement in their feelings about their self-efficacy, their ability to engage in multidisciplinary working. Okay. Now, in order to assess the outcomes, we used a comparative design. So this is a sort of quasi-experimental approach, whereby for the students on the course, we randomly selected from their caseloads a number of service users or clients with severe mental illness who were likely to be receiving the intervention for at least the next 6 months. Okay? And so we measured changes using measures over a 6-month period. And then we created a comparison group of service users who were randomly selected from caseloads of mental health practitioners working in teams in 2 districts where there were no similar courses to this running. Okay? So we had 2 groups that we thought, well, if there's going to be an improvement in the caseloads of the students who are on the course, and there's no change or things get worse in the comparison group, then the argument can be that it's going to have something to do with the course. So the kinds of things that we did was use measures, but actually also we created with the help of service users, a questionnaire of the issues, things that they thought were important. The advisory group of users said, well, it's really important that we are treated as people with mental illness with respect, and that the practitioners understand us and our experience of mental ill health. Okay? We also think that practitioners must be able to work together effectively, because we don't want to have different people telling us different things, or services being uncoordinated and us having to go one person in one place and another in another place. Okay? So just take those as examples. The first thing is that actually in both the comparator group as well as the intervention group, the training group, that the users, almost all of them, said, these practitioners do treat us with respect. They do understand our experience in mental health. That's good. Okay? Multidisciplinary working, those in the training group, the 77% of the participants endorsed that. But again, it wasn't so bad in the group that didn't have the training, 70%. Okay? The key area that was a difference was actually in the planning of their care, right? And they wanted the professionals to involve them as users in as much as they wanted in the planning of the interventions that they received, rather than the professionals just deciding what's important to them. And here we have a very big difference, because the participants on this course clearly had taken that message to heart, and the service users perceived that. So we had a difference of 81% versus 59% in that particular area. Okay, so we used measures to assess clinical outcomes, and these related to their general social functioning, to the reduction in their mental health and social problems, and in their psychiatric symptoms. And there were statistically significant improvements in the intervention group, the training group, in all of those particular areas. But the question is, can this be attributed to the training? Well, you may not be surprised to know that in the comparison group, there was also a tendency for ratings to improve. You know, it's not that these professionals who didn't have the training weren't doing anything. They were actually trying to help people, and there were some improvements there. Okay? But the key difference was actually in relation to the area of life skills, which for people with severe mental illness like schizophrenia or OCD or something like that, are particularly important to them. Okay? And what we found there was that there was improvement in the student group, but there wasn't any change in the comparators group. And you can actually see that in this chart here. Cohorts 3 and 4, the red and green, is actually showing, this is one of these stupid measures, if you like, where it's done inversely, so that a lower score is better. Okay, so that the red and green things have improved because the scores have decreased, right? Whereas in the two blue groups, the scores have tended to increase. So, and what's good about this, and it's always useful if you're doing this kind of research, is if you can have more than one cohort involved, so that you can see if there is an effect in one year, are you going to get the same effect in the following year, which is exactly what we did here. And then if you can replicate it, which we did in another university, and we had exactly the same things going on. So we can have confidence in the evidence, even though it is not a randomized controlled trial. Okay? Incidentally, I do randomized controlled trials now, but that's a different story. So, there was other evidence, there have been some other evidence of positive outcomes from interprofessional training in a number of different areas. For example, in palliative care in the United States, in services for victims and survivors of interpersonal violence in the UK, in neonatal intensive care in the USA, and in training to reduce the incidence of adverse incidents in emergency care departments in the United States, and then also in stroke rehabilitation units in the United States. Okay? Now, actually, you might say, well, that's the only evidence that you've got that interprofessional education is effective. Oh, well, the answer is yes, actually, that the systematic reviews that people have undertaken, or best evidence reviews, are actually been quite good at identifying changes in attitudes, right? Changes in intentions, but it's much more difficult to actually get to changes in outcomes for patients or service users as a result of these kinds of interventions. Okay? And actually, if you look at just uniprofessional outcomes in uniprofessional education, like social work, for example, which I obviously know quite a lot about, you actually find that it's extraordinarily difficult to find evidence that, good quality evidence that social work education is effective, right? Of course, those of us who are educators in this know that it's effective, right? But we need the evidence, right, to show that it is, and to know which methods work better than others. Now, I'm just concluding here by saying that interprofessional education won't solve all of the problems experienced in interprofessional and interagency working. And that's because barriers to cooperation are structural and organizational, as well as educational and attitudinal. Structural because people keep changing structures and think that's going to be an answer, but it's not sufficient. Okay? But we do have some evidence that attitudes can be changed, that knowledge and skills can be increased, and that skills can be implemented, and the beginnings of some evidence that there can be beneficial outcomes for service users. And I just want to acknowledge some of my colleagues who I've worked with over the years on these particular projects. So, for those of you who are at the university, if you want to follow up any of this stuff, then one of the ways in which you can do it is a book that I understand is now in the library that I wrote with Helen Dickinson on this particular topic, and there's a list of references that you'll get if you want to follow those up when you get your copy of this presentation. So, questions? Yeah.